Good afternoon, everyone. We are going to give just a few seconds here because it takes just a little while for everyone to come in from out of the waiting room. And we do not want to get started too quickly and have people miss anything. Today is the second in our four-part series on quality improvement and things like that for frontline staff. Today, we are talking about quality improvement. It is all hands on deck when this comes to play. We need everybody at the table helping us out. And so today we're going to talk about kind of the why behind quality improvement, why we need to do it, what quality improvement is, and then what your role is in quality improvement itself. So these webinars are, we are able to bring these to you as part of the quality improvement program that we have for critical access hospitals. This is the Medicare Beneficiary Quality Improvement Program that comes down from the federal level and it comes through the State Office of Rural Health. So we partner with everybody over at SOAR to help bring you all of the education. All of these webinars are free to attend. We don't charge anything for them at any time, and we're able to give some C&E for those. So we appreciate you joining us on these. Getting back to the continuing nursing education credit, there is 1 credit hour per webinar in this 4-part series. So what will happen at the conclusion of the series after that 4th webinar, we will send out a link to the evaluation, and then you just go in and do the you'll be able to select the webinars that you attended. We kind of go on the honor system. You just click the box on the ones you attended, you complete the evaluation for those webinars, and then you're going to get your C&E certificate for the appropriate amount of continuing nursing education credit. If you are non-nursing, you will go through the evaluation just the same, but you'll get a certificate to show that you attended the webinars. If you are watching in a room where several of you are, say, in your conference room or something like that, watching together, it's really important that you at least go in and register individually, because otherwise I would not have your email address to be able to send you the continuing education information. And then you may miss out on that because the portal window is only open for about 30 days once we send it out. And so we want to make sure that everybody gets the credit for the webinars that they attend. Just a couple of learning objectives for today. Again, we're going to talk about kind of the why behind quality improvement, the basics to quality improvement, and how we use our data and things like that. And then, of course, what the role is for frontline staff in quality improvement processes. And that is not just applying to clinical backgrounds. This applies to everyone inside the hospital. So whether you are in medical billing and coding, whether you're working in food service or housekeeping, doesn't matter. Everybody has a role to play in quality improvement. Just a quick question to get us started and see what you know about medical errors and things like that. In a typical hospital, approximately what percentage of errors do you think are actually reported? And so if you have a guess, go ahead and put that into the chat box. We'll give everybody a few seconds to maybe make an answer, but do you think it's less than 5%, maybe between 25 and 50%, 75%, or between 80 and 90%? I see a lot of A's and B's. Lots of A's and B's. Oh, 1D. So a good bit of answers there. So you might be surprised to know that it's actually less than 5% are actually reported. And when you think about that, if less than 5% of errors are actually reported, when we get numbers back and statistics that tell us how many medical errors occur, then clearly we're very much under the actual number that it would be. So this is kind of why we need to think about the quality improvement processes, because we need to get to a point where we are at that at minimum 80 to 90%. Ideally, we would want 100% of errors to be reported, but we certainly need to do a little bit of a better job in reporting the things that occur inside the hospital in the clinical area. So just a few statistics about Texas, because I think it's really important, especially at the critical access hospital level and the rural hospital. I think it's really important that you understand the scope of Texas in general and our size and what our resources are in terms of healthcare, because you have to understand how absolutely essential you are to the populations that you serve. Texas itself is the second largest state. We have almost 270,000 square miles. Texas is huge. You can leave from the center of the state, drive it for about 8 hours in just about any direction, and you're still in Texas. So we have approximately 30 million people that live here based on the last census information. We have 51 of our counties, that is roughly 16% of our population, that are considered completely rural. That means 4.8 million people live in that area, and we have 91 critical access hospitals in Texas, which is more than any other state in the United States. Not surprising given our size. This map is really interesting, and it gives you a good picture of access to healthcare when it comes to our rural area. If you look at the blue diamonds, those are going to be your critical access hospitals. You have the stars that are rural health clinics. Then you've got the red squares that are our qualified health centers in the rural area. And then, of course, the orange circles are the short-term or PPS hospitals in a rural area. And then when you see that yellow, the little yellow colored sections, those are the areas based on census data that have a population of greater than 50,000 people or more. And those are considered to be our non-rural areas. So if you look at this map, you're talking about San Antonio, Austin, the Dallas-Fort Worth area, Houston, and then, of course, a little bit out in El Paso and some down the border around Laredo. The rest of the state is considered rural, which is a huge, I mean, it's the vast majority of our state. And if you look real quickly, especially up in the Panhandle and kind of out in West Texas, you can see that there are some complete counties that are completely white. They have no critical access hospital, they have no rural health clinic. And so those are places that are very underserved in terms of access to medical care. And with that being said, in those rural areas, you may be the closest facility to some of those people. And that's why it's really important that we make sure we do everything we can to protect the quality of care in our critical access and rural hospitals and make sure that you're able to sustain yourself from a financial perspective. Now, if you're not aware, the critical access hospital designation is something that there is criteria that hospitals have to meet in order to get that designation. So you have to be licensed for 25 acute care beds or less. So that does not include swing bed. You have to be located more than 35 miles from another hospital. There are some exceptions that can apply to this, but that's a general rule. And then you have to maintain an annual average length of stay of 96 hours or less for those acute care patients. You also have to provide 24/7 emergency care services. So this is kind of an area where some of our hospitals may just slightly not meet this criteria and end up with that rural designation. And so sometimes it can be a little more difficult on those hospitals even than critical access. Now, what does the data tell us? We have to look at some of the data, which may be the not so pleasant news to talk about. We still have to look at it because, again, this goes back to why this is setting the foundation for why we do quality improvement and why it's so incredibly important. First of all, we know that about 250,000 people die each year from medical errors. It is listed as the third leading cause of death behind cancer and heart disease. And these are things that are, for the most part, preventable errors, things that we actually contribute to. And medical errors are cost approximately 20 billion with a B dollars each year. And there's even some estimates that say it's far greater than that, where it's about 35 to 45 billion just for healthcare associated infections alone. One catheter associated urinary tract infection can result in over $10,000 in costs. And keep in mind that when we produce some type of a medical error or injury, those costs are absorbed by our facility. We don't pass those on to the patient or to their insurance carrier or anything like that. We have to bear those costs when it's something that we are responsible for. The average cost of a patient fall with injury in a hospital is sitting around $30,000. So when you think about large hospitals like a Parkland or a university health system or Memorial Hermann, they're such large organizations with high patient volume. Not to say that medical errors or patient injuries are acceptable in those hospitals, but when they do occur, they can absorb those costs a little better than a small critical access hospital who has very low patient volume to begin with. So that's why sometimes, even at the critical access or rural hospital level, our quality is even more crucial to pay attention to, because a couple of these, like for instance, a couple of patient falls with injury, that's almost, getting close to the annual salary of another staff member. And so think about if you feel like you need more staff, but you don't have the uh, the funds to add them. I mean, it can be huge to an organization. So for critical access hospitals specifically, again, they're smaller in size. You do have lower acute care inpatient volumes simply because of your location and access to people. It's not like being in an area like Austin where it seems like there's either a hospital or some type of an urgent care clinic or a freestanding emergency department on every corner, and a large population of people to utilize all of those services. You're in a smaller geographical area with a lower population, so you just have lower acute care volumes. Critical access hospitals will operate with the least amount of resources, and you just simply cannot absorb the costs associated with the patient harm events. And our critical access and rural hospitals are always at the greatest risk of closure simply because financial instability and things like that. How quality improvement helps, first of all, high quality care is also efficient care. And when we get very efficient with our processes and we're providing good quality care, that comes at a reduction in cost. So not only is it lower cost for your hospital to deliver the care, it's lower cost to the patients. And that, of course, is going to lead to patient satisfaction. I mean, when they're happy, they feel like they're taken care of when they're in your hospital. They're going to come back for their healthcare needs. And on top of that, they're going to tell everybody about it. If you haven't heard the phrase, it goes something to the effect of, if something good happens, you're going to tell 5 people. If something bad happens, you're going to tell 500 people. And in a day of social media where the reaches are far greater than that, certainly ideally providing good quality care, that word would eventually get out the same as or greater than if something negative happened. And that would also lead to not only patients coming back to you, it would decrease your out migration, but it may result in people in neighboring areas to come to you for care, which would increase your patient volume. Happy patients are going to lead to happy staff. When people come in and they trust you, they know that you're going to take really good care of them or their loved ones. They are just so much easier to work with and deal with with the things that we have to do. So that's going to lead to your staff is going to be happier about what they do, and that leads to less turnover. And if you think about the use of travel nurses, agency nurses, those come at a high cost to fill vacancies and fill in where it's needed. And staff turnover is incredibly costly when you start adding up how much it costs to bring in, train new people, get them off of orientation only to have them leave. And we know that there are challenges in the rural area of, number one, recruiting people to come to the rural area and keeping them there. So ideally, we would want to do everything we can to reduce our turnover. Now, part of quality improvement, there are federal quality improvement programs, and this kind of just to go into some of what the benefits are to participation and what helps drive some of the quality improvement initiatives that go on inside your organization. So this program itself, this one specifically, again, the Medicare Beneficiary Quality Improvement Program, or FLEX program, we've kind of coined it the Critical Access Hospital Quality Improvement Program. But this is coming down from the Federal Office of Rural Health. They funnel the funds for this through the State Office of Rural Health, and Texas A&M Rural and Community Health Institute and Texas Hospital Association partner with the State Office of Rural Health to help bring you education, technical assistance, and things like that. There are several core measured domains. It is patient safety and inpatient, patient engagement, care transitions, and outpatient measures. So we look at those 4 quality domains as part of this program. Benefits of participation: number one, we can provide technical assistance on quality improvement. So if your organization is struggling with something quality related and you need a little bit of assistance, maybe you've kind of exhausted your ideas and you're not sure how to achieve improvement in a specific area, we can come in and sit down at the table with everyone and work through the process and offer suggestions and help you out. If you have a new quality leader who needs some education to fully understand their role, we can come in and do that. There's also technical assistance in finance, which is absolutely essential to the sustainability of an organization. Free education for quality leaders and frontline staff, just like these webinars. We also do quality improvement boot camps. And we just completed a workshop for our CNOs at the critical access and rural level. We are also advocates for our critical access hospitals and rural hospitals at the state and federal level. We understand the struggles that you have, and we try to act as a voice for you through Texas Hospital Association when it comes to discussing things like new legislation and how it's going to impact our hospitals and the care that you deliver. Participation in these type of programs also gives your hospital the ability to qualify for or participate in other grant-funded programs. Some of those help provide funds for things like capital improvements. You may need some new hospital beds. Maybe you need some new monitors or things like that. And there are grant funds out there available to your hospitals if you simply participate in quality improvement programs and show that you're doing your part to improve patient care. Now, this will give you an idea of the core measure set that we look at for this program specifically. These are, of course, not all of the quality measures that are measured inside your hospital, but these are the ones specific to this program. We have a quality improvement infrastructure survey, which looks at how the quality improvement is structured inside your organization and how it is part of your overall goals and strategic plan. We look at healthcare influenza vaccination for healthcare personnel only. We look at antibiotic stewardship, safe use of opioid medications. We look at HCAP scores to look at the patient experience. In care coordination, we're looking at hybrid all-cause readmissions and the social determinants of health screening and those that screen positive. And so you may have noticed inside your organization that you now have to screen patients for some of these social determinants of health. That is part of a federal drive towards addressing some of these issues in our populations and improving the health of our communities. And in the emergency department, we're looking at transfer communication, making sure that all of the information that's essential goes with the patient when they're transferred to another higher level of care. We're looking at our ED throughput to see how long our patients are staying inside your emergency department, and then those that leave without being seen. Now, there is a hospital commitment to health equity listed there, but that was removed at the beginning of the year, so we're not doing that survey going forward. Now, talking about those measures, let's talk about quality improvement and what that process actually is, because it's a lot more than someone simply collecting data and reporting a number to you. So quality improvement is where we strive to make a difference in the patients and the care that we provide by making sure that it's safe, effective, and that we deliver that care, first of all, by making sure that we fully understand how absolutely complex healthcare actually is. We work in a very highly complex industry. And so understanding that and knowing that there are so many moving pieces that have to come together and work together in order to deliver effective care is really important. It is a systematic approach. It is not one department working in isolation to provide care. So it is not just the nurses at the bedside to deliver care. It involves everyone from the laboratory and those that come to draw blood and run blood tests, the pharmacy filling prescriptions. It is your dietary service to prep the meals and everything for our patients and make sure that their nutrition guidelines are followed. It is housekeeping to make sure that not only occupied patient rooms stay clean, but when there's a turnover, that the rooms are turned over in a timely manner so that new admissions can be brought to the floor. It is your medical records billing and coding to make sure that all of those diagnoses and the care provided is actually billed appropriately so you actually get paid for the work that you do. So it is a systematic approach. It is not just one small group here or there taking care of patients. We design, we test, we implement change. And while we're doing that, we are actually collecting data in real time as we're doing it to make sure that whatever change we're implementing is actually working and that we do not need to make any modifications in the process while we're trying to develop a new change program. So the different parts to quality improvement, of course, there's the data collection and analysis, and there is a large amount of data collected within a hospital. The measures that I showed you is just the tip of the iceberg because we are also collecting data on all healthcare associated infections, patient falls, medication errors. So there's so many other pieces. Every department in your hospital has quality improvement metrics that are collected. We have to develop action plans. So when we identify an opportunity for improvement, we have to come to the table with everyone and sit there and come up with a plan to set into place so that we can actually improve whatever that issue may be. When we implement that change, we always start on a small scale before we roll things out across the board. But again, there's continuous monitoring and data collection while that's happening so that we know what we're doing is actually working. And then once we achieve success, we have to continue to monitor for a period of time to make sure that we have sustained improvement. And usually that takes about at least 6 months of continuous data collection to make sure that the change that we achieved is going to continue and that it wasn't just kind of like a false sense of success there. So just because you get to a point of improvement doesn't mean the work stops there. We have to keep it going. So who decides what data we collect? First of all, we have things that are reported through our hospital reporting mechanisms. This can be staff concerns or staff reports. When you identify something that could potentially be an issue or an error is made, or maybe even a near miss opportunity, and you report that, that becomes something that may turn into a quality measure. We can have patient complaints that come through looking back at HCAHPS scores and patient satisfaction. If we have a lot of complaints that come in that say we do not have a nice, quiet environment, we may put a quality improvement measure in place for that so that we can look to improve. And also surveys. Your employee satisfaction survey could be an area to identify improvement. So all of those things are places for us to collect information and develop quality improvement measures. We also have quality improvement project participation, such as the MB Quality Program, this program itself. There were also a program several years ago called HIIN, which was the Health Improvement Innovation Network. And that was a CMS-driven quality improvement program with the intention to reduce patient harms by 20% over the course of that program, which we did, by the way, for the state of Texas. The follow-up iteration to that was HQIC, and the next version will be the 13th scope of work. But these are all federally funded and driven quality improvement programs where they set out a specific set of quality measures for hospitals to collect and improve on. And then we have our regulatory agencies like CMS, who sets out their conditions of participation. We have state agencies who will also require certain pieces of information and data to be reported. And then you have organizations like Joint Commission and your accrediting agencies, which may also put out some type of quality and metrics that they would like to see. So basically, the whole quality improvement process, we start with the data collection. We don't know if we need improvement if we don't have data to look at. So it starts with the collection of data or finding out that there is even an issue to look at. And then your quality improvement committee will sit down and take a look at that data. They'll come up with an action plan, and they'll put that into place and start working towards improving the data and making sure that they achieve success. All of this information gets reported up to your hospital administration at the executive level, and then it also gets related to the reporting to the hospital board, because ultimately your hospital board has oversight to what happens inside the organization. They are ultimately responsible. Now, we operate off of what we call the PDSA cycle. You may have also heard it called PDCA. They are both the same thing, just a little bit different verbiage in the acronym. But this is basically Plan, Do, Study, Act, or if you go by PDCA, it is Plan, Do, Check, Act. And so this is the process that we follow for quality improvement. The first thing that we do, again, is the plan phase, where we have collected that data, we've analyzed the data, and then we're coming up with our action plan. We need to know who's impacted by what we're about to, what the issue is, and who will be responsible for the change, what the change is going to be, when we're going to try to carry that out, in what department, and how we're going to do it. So this is where we come up with that action plan. When we get to the do phase, that's where we put our plan into place on a very small scale. We never try to roll things out across the board because we're not really sure if it's going to be successful. So we start small, because while we're collecting data during that do phase, when we get to study, we may evaluate it and say, this little piece of our plan isn't working as well as we thought. So maybe we need to make some modifications. So we make the modifications, and then we put the plan back into action and test it until we achieve the desired result. And then once we achieve the desired result, then we're going to act and put it into place across the board for full scale change. And so this is an ongoing cycle that always takes place. It's always revolving. And again, there's continuous data collection throughout this entire process. Now, when it comes to quality improvement, everyone has a role to play. Your hospital board, these are typically community leaders who have either been elected or appointed to their positions. They are invested in the success of your hospital. They have to be invested in the success of your hospital. And they have a big responsibility to the entire community to make sure that your hospital remains sustainable and remains open to provide care. Now, going back to CMS, when we talk about where we get some of our quality improvement measures, CMS has conditions of participation. If your organization agrees to take patients that are funded through Medicare and Medicaid, and your hospital wants to participate in those programs, you are bound by law to comply with the conditions of participation that CMS puts out. One section in those conditions of participation is very specific to quality improvement, and it states that your hospital board is ultimately responsible, and that quality improvement has to go across your entire hospital. So not just in your clinical areas, but in all the others that I've mentioned, like medical records, your dietary service, etc. Now, after your boards, you have your C-suite. So this is your executive team. This would be your CEO, your CNO, your CFO. If you have a chief operating officer, all of those C-level people are part of your C-suite. These people can sometimes make or break your ability to successfully achieve change. They have to understand the importance of quality improvement to the success of your organization, and they have to support those activities. And then as you move down the ladder, you have your department leaders. They have to provide guidance to those within their department. They certainly help facilitate change. They really have to help you understand why you're changing things and not just come in and tell you, okay, we're going to do things different now without you understanding why. Because I wouldn't want to change something if there wasn't a reason that I really needed to change it. So if I'm not aware of that, I would probably be a little resistant too. So it's important that the department leaders can effectively help you understand why the change is important. And then we get down to the frontline staff. And I know frontline staff comes at the bottom of this slide, but that does not mean that you are the lowest piece of this process. Because when it comes to quality improvement, you are the ones who help us identify the need for change in the first place. You have probably one of the most critical parts in doing so. You also are the ones who have to actually put the change into place and do what needs to be done to achieve improvement. You help us identify the ways to make that change even better. We can't always understand how to best do your job. You're the expert in your role. As a nurse, I wouldn't begin to tell you how to do the work in the laboratory. I need the people in the laboratory to give feedback as to how something isn't working or how it is. And you yourself ensure success of the improvement projects that we have. And we absolutely hope that all of you are willing to share ideas and best strategies based on the work that you do, because sometimes your ideas are the best. You just have to share them with us, share them with us. So who's responsible for quality improvement? The answer is simply everyone. It goes back to all hands on deck. Everybody has to be ready, willing, and able to be a part of the process and help facilitate the change that we need. And reporting is key. So we're going to talk about how you do that and what your role is. But first, let's talk about a couple of barriers, because if we know the barriers, you can see how we can get around those and we can be more successful in quality improvement. So first of all, quality improvement relies on that engagement. We need you as frontline staff to be fully engaged. We need you to report things that are in your area of work that could be of concern and identify those issues. And we have to start changing our organizational culture to one of a culture of safety and high reliability. And I'll touch on high reliability today, but next week we're going to go into depth about that, and hopefully you'll really understand high reliability and how your organization can move to that. But it's really important to remember when it comes to quality improvement that none of us wake up in the morning and think, I'm going to go to work today and I might make a mistake and I'm not going to be concerned about it. None of us really want to go make mistakes or create an error. But it's really important to remember that most of the time when something happens, there's something in the system that actually sets the stage for an error to occur. And so when we fully understand that, I think we're more ready to report things as we identify them, because once we fix that problem within the system, then we will prevent that from happening again. Some of the barriers to reporting: clearly fear of disciplinary action. Historically, errors and mistakes, it's kind of been a punitive environment where you're afraid that you're going to end up with a write-up or you're going to end up being disciplined in some way. Embarrassment in making mistakes. No one wants to make them. And we all strive very hard to do good at our jobs, but sometimes mistakes do happen. And of course, pride can get in the way sometimes. So how do we overcome those? It goes back to that culture of safety that I mentioned before. Building a culture of safety is one. This is the official definition by the Agency of Healthcare Research and Quality, which is AHRQ. And they define a culture of safety as one in which we're held accountable for unprofessional conduct, yet not punished for human mistakes. Errors are identified and mitigated before harm occurs, and systems are in place to enable staff to learn from those errors and near misses and prevent a reoccurrence. And so, yes, if we are not acting in a professional manner or functioning within our scope of practice, I mean, yes, there should be disciplinary action for that, but simple human mistakes or problems within the system that help create those mistakes, those are things that we should be celebrated more for reporting them so we can prevent those big patient harm events from happening. So a culture of safety encourages reporting those near misses. We have a very heightened sense of awareness of safety. It's where we put safety as the top priority issue. It's almost like you become programmed to look for potential problems so that you can stop them before something big happens. An example I can give you from a healthcare related, a big issue when we talk about system errors. An example of this would be several years ago, there was a situation at Vanderbilt in which a nurse made a very significant medication error. She was a float nurse bouncing between departments. She was called to one department for a procedure and then got redirected. She had an orientee at the time, and she was supposed to give a medication for sedation in radiology for a procedure. When she tried to pull the medication for the patient, it kept locking her out and giving her a warning that it was unavailable. Well, she overrode the safety mechanism to draw the medication multiple times and then ultimately pulled out a wrong medication and gave it to the patient. The patient ultimately suffered an event and passed away and died. The nurse was held criminally liable, but in the whole investigative process, they discovered that this had been going on at Vanderbilt for years, where the staff were comfortable overriding the safety features of the medication system to pull medication. And it was just nobody had reported it. If it had been reported, nothing was done to fix it. And so ultimately it ended up in a catastrophic patient event. So when you have a culture of safety, this type of thing is what everyone would look out for. And you would be the loudest voice out there saying, this is a problem. This could create a potential safety issue and we need to address it. When you function at a high reliability, this is where sometimes change comes, it's a directive from the top down. So from your leadership level down to the frontline staff, kind of like the chain of command in the previous slide, going from the hospital board to frontline staff. But when you're functioning at a high reliability organization, it tends to go the opposite direction. So those on the front line are really empowered to speak up. They're empowered to take control over, take ownership over their environment, bring up issues that they identify, and be a part of actually facilitating change. And so that's why we really look to our frontline staff to report those near misses so that we can learn from them. And we can facilitate change so that they do not actually get to the patients and cause harm. Again, fosters reporting and encourages participation at all levels. It makes quality a true team effort and not just one person in your organization who's trying to lead quality and facilitate change. Everybody's highly engaged and everybody's involved. So what does all of this mean for you as a frontline staff member in whatever department that you work in? You actually have so much power in quality improvement, and you may not even realize that. You are usually the first people to recognize that there's a potential issue. You are the experts in your area of work. Like I've said before, if you work in patient registration, you know the process and flow of what you do. So if we need to change a process, you're the ones who need to come with us for the best ideas on how to do your job. We wouldn't know if you didn't tell us. So you have the ability to bring all of those ideas to the table. And you have the ability to really lead change and impact not only the care of the patients inside your hospital, but your entire community and their benefit, because the better your processes are and the more efficient and the higher quality care you deliver, the healthier your community is going to be. And so you're not just impacting people inside your organization. You can ultimately be an impact on people outside of your hospital as well. So what you can do, clearly report. Don't wait until there is a significant patient harm event or a significant error inside your organization to make a report. Those near misses can prevent something so much bigger. And if you report that near miss to your manager, and you feel like, nothing's going on, it continues to be a problem, then take it to your quality leader and let them know. Don't just sit back and think, well, I told him this could be a big problem, but nothing's happening, so I'll just let it go. Because ultimately, at some point in time, somebody can get seriously harmed by a medical mistake. Somebody could even lose their life from a medical mistake, and we wouldn't want that to happen. So stand up and speak up and take ownership over your environment, what your role is, your specific area, and don't be afraid to collaborate and come together with others. Because going back to how healthcare is a team activity, we cannot make change to what we do as nurses without consulting the laboratory and the pharmacy and other departments in the hospital, because something I change in my process can impact what you do in your process. So that's why everyone needs to be at the table when we come up with action plans to address change. So do you know what your quality structure is inside your hospital? Who's responsible for quality improvement? Who is your quality leader? Because your quality leader is the one who has oversight of quality at that level. And so they are not only have to know all of the data measures being collected in your hospital, but they have to know all of the quality improvement projects going on. So who is that person, and who could you go to and ask for information if you wanted it? Who reports your quality information? Who from your department reports your quality data? Like, what measures is your department collecting? If you don't know, ask someone and ask to see the data, because you should also know how well your department is performing, because that gives you an idea of where your opportunities for improvement are. You may not even be aware of what data is being collected or what projects are going on in your department, but you should, because you're the ones helping to facilitate that change. So going back to what is reported and getting that information, and then what's done with it, where does it go? Who addresses the concerns, and who's coming up with the action plans? We always encourage involvement. Again, learn what your hospital's reporting and where that goes to, and maybe assist with some data collection. Sometimes when you're asked to audit medical records, for look for things, and you're asked to just do some chart audits, it isn't necessarily that we're trying to give you busy work and things like that. That gets you involved in quality improvement processes, because we need to make sure that documentation is accurate, because documentation impacts your billing and reimbursement, but it also can reveal errors in medical care or things that we could improve upon. So be a part of the data collection and learn how to analyze that data and identify opportunities for improvement, and learn how to track that data looking for trends, and then follow where it goes inside your organization and see who's taking that data and putting together some data plans, uh, uh, quality improvement plans. Participate in a quality improvement team. If there's an opportunity for improvement in your department, be a part of that work and get involved in it, to sit there and brainstorm and come up with ideas on how to facilitate change and bring those ideas to the table. Help develop those strategies to put into place, and be the champion on your unit or your shift, whatever the case may be, to help facilitate change, because there always needs to be a champion to help bring it and help everyone else understand why it's important, why the change is needed, and what you plan to accomplish. Be that voice, not only within your department, but at your hospital level too, with your department leader and with your executive team. Don't be afraid to stand up and speak up. Always remember, absolutely, you are the key to our quality improvement because without you on the front line, we could not facilitate change and we could not improve the things that we do. We absolutely cannot do it without you. And you have all the ability to lead the way to success in your organization. You have the ability to make or break quality inside your hospital. And only you can tell us how you can do your job better. I can't go in and tell a physician how to improve their practice. I mean, I can identify issues where they don't follow standard of care, but when it comes to modifying their process, I need them at the table to help me understand what they currently do and how we could potentially do it better without completely messing up something else in that process. So only you can tell us how to do your job better. And so we absolutely need you. We need all of you, and you're critical and important in everything that we do. So with that, I ran through all of that pretty quick. It's a lot to digest, but I'm going to open it up for any questions. Just a quick note, Judy placed in the chat the link to our webpage, and that is where we post the recordings of the events. All of these webinars are recorded, and you can go back after the fact and watch them. If for some reason somebody misses it, just direct them to the recording. But I'll give it a few minutes to see if we have any questions, and you can put those in the chat box. Very encouraging and informative. I'm glad you think so. Like I said, we couldn't do what we do without everybody on the frontline staff. And we all started on the front line at one point in time. There's not a lot of education for us in quality improvement. You do not get I know in nursing school in general, you do not get a lot of education on quality improvement. Even as I went forward and completed my bachelor's degree and ultimately my graduate degree, you just don't get that much information on it. And so I encourage everybody to go do some research out there and educate yourself on quality improvement. Cassidy asked if anyone had a fun or engaging exercise with staff for bringing forward quality ideas. Yeah, if anybody's done anything in their organization you want to share, drop it in the chat box. I know it's always fun when you can kind of make some sort of a competition out of it and give a prize for the best idea or the one that ends up being the idea that facilitates the change. And sometimes with your staff, even the little things are important, like whether you give them recognition in your employee newsletter, if you have one of those, or giving a shout out on social media. Things like that sometimes do not have to be of high cost value, but they can be very important to staff and in terms of getting that recognition for doing something really great and having those really great ideas. But if anybody else has any good ones, drop those in the chat, or you can always send me an email offline if you want to do it that way. But that's a good question. And if you're a frontline staff member, what would engage you? What would encourage you to bring those ideas forward? Put that in the chat box. What would make it worthwhile to you to be more involved and engaged and speak up with ideas that you have? So we have the 2 remaining webinars that we have. Next week, we will be talking about high reliability. And again, I think high reliability is really important when we learn how to facilitate change from the front line up. And so I hope you'll join us for that one. And then our last webinar on August 19th, we are going to be talking about AI because there's so much out there and there's so many advertisements for AI tools in healthcare and how to make our jobs easier and everything else. But what do we need to know about that? And what are some of the precautions we need to take? So I'm kind of looking forward to that too. This is my contact information. So if you have any questions, please feel free to reach out to me at any time. I'm happy to try to answer any questions that you have. If I don't know the answer, I will do my best to find it for you. But again, we're happy to reach out. And if your hospital would benefit from some technical assistance or something, please let us know, because we can come out and do hospital site visits as a part of this program, and we're happy to go anywhere and visit you guys. I love going to our rural area and visiting our small hospitals, because I grew up in a small town. I love the rural area, so it's actually kind of really important to me, because I know what you do. So, and how hard it is for you to do it. So again, please feel free to reach out to me at any time. Also, if you have a topic or something that you want to see education on in the future, please make sure that you let us know when you do the evaluations. I read all the comments that come in on our evaluations, and that is my quality improvement process for the education we bring you. And we want to make sure that you get the education that you actually need and want. And so if you have topics for the future, please put those in there. So with that, thank you again for joining us. You're going to get back about 10 minutes of your day. So you got a little bit of time to maybe grab a cup of coffee before you head back out to take care of your patients and do the rest of your duties for the day. But we thank you very much, and we hope you have a great rest of your day. And we will see you all again next week.